Now let's discuss rheumatoid arthritis. So it is a chronic autoimmune disorder. It primarily involves the joints. Okay, so there is symmetric involvement of the joints, especially the small joints. Okay, that is what you need to remember. The exact cause is unknown. So it follows usually some viral infections. So EBV, CMV, parvovirus, rubella, and sometimes mycoplasma as well. So there is genetic predisposition. There is increased incidence in monozygotic twins. Also HLA-DR-B1 allele association is seen. Female gender, cigarette smoking are risk factors. So pathology. First, there is chronic inflammation, granuloma formation, because you see subcutaneous nodules, right? That is important in skin of rheumatoid arthritis patients. You see subcutaneous nodules, okay? And so chronic inflammation, and joint destruction, okay? Rheumatoid arthritis joints, okay? So the earliest change is swelling and congestion of the synovial membrane, okay? Here you can see the synovial membrane. There is swelling and there is inflammation of the synovial membrane, and there is chronic. It is chronic, right? So lymphocytic infiltration. So lymphocytes, plasma cells, and macrophages. These inflammatory cells in the synovial membrane, they release cytokines. Okay, this causes differentiation of B cells into antibody-producing plasma cells. These plasma cells produce your classical RA factor and anti-CCP. Okay, they contribute to joint destruction. So because of the inflammation of the synovium, there is synovial hypertrophy and effusion of synovial fluid into the joint space. Okay, this causes joint swelling. There is formation of pannus. Okay, this spreads over and under the articular cartilage and damages the articular cartilage. So there is synovium inflammation. Then there is effusion of the fluid. This causes swelling. So then there is granulation tissue again after inflammation. So pannus. And finally, the involved joint may develop fibrous or bony ankylosis. Then the muscles adjacent to the inflamed joints, they atrophy, and there can be lymphocytic infiltrates. Subcutaneous nodules are there, so there is central core of fibrinoid necrosis surrounded by mononuclear infiltrates. Okay, a palisade of mononuclear cells with collagen. So rheumatoid vasculitis involves the medium and small arteries and venules. Okay, there is lymphocytic infiltration there also. So again, articular features. So basically, you can see symmetric polyarthritis of insidious onset. Okay, so the joints involved are MCP, PIP, MTP, and elbow, shoulder, knee, all of these, etc. Wrist, MCP, wrist, and PIP mainly. But see, distal interphalangeal joint is spared. That is what you need to remember. So even if there is asymmetrical presentation initially, it becomes symmetrical as the disease progresses. Okay. Then predominant symptoms, they are stiffness of the joints. It is especially more in the morning because after prolonged immobilization while sleeping on the bed, you are waking up. So there is stiffness, morning stiffness of the joints, and there is swelling of the joints. Why? Because of leakage of synovial fluid and all that, and synovial membrane hypertrophy and all that. And especially joint deformities may be present. Okay, so swelling of the proximal interphalangeal joint may give rise to spindle shape appearance of the fingers. If this is the proximal joint and this is the distal joint, if this is swollen, okay, this can cause spindle shaped appearance of the fingers. Okay, so distal interphalangeal joints are spared in rheumatoid arthritis. You need to remember that. Okay, in osteoarthritis, they are involved. So swan neck and boutonniere deformity. See, I like to remember it as boutonniere, write it as a B. Okay, initially the proximal interphalangeal joint is flexed, okay, and distal is extended, okay, but in swan neck deformity it is the exact opposite. The proximal interphalangeal joint, just write it like an S, okay, the proximal interphalangeal joint is extended and the DIP is flexed. So swan neck and boutonniere deformity, just draw the diagrams. Then then extra articular features. See, start from top to bottom. Okay, from the top you have eye. So you will have anterior chamber involvement. So scleritis, episcleritis. Usually you won't see uveitis. Okay, then moving on to skin. Okay, eye, then skin over the face. Okay, so skin, you can see rheumatoid nodules. So you especially they develop over the pressure points. Okay, so you have the olecranon process, the scapula, okay, sacrum, occiput, etc. Okay, so again, for painful nodules or something that interferes with joint motion, you can give intralesional steroids. Okay, next, other skin manifestations, you can have ulcers on the skin, vasculitis, okay, pyoderma gangrenosum, all that. So eye and skin. Then moving downwards, so respiratory and cardiac. See, cardiac, everything is involved. Okay, so itis, pericarditis, myocarditis, endocarditis. Okay, and again coronary vessels. So cardiovascular, cardio, again all are itis, vascular, so coronary vessels, coronary vasculitis, it can lead to MI. So respiratory, again synovial effusion in the joint, pleural effusion in the respiratory system. You can also have Kaplan syndrome, so rheumatoid arthritis associated with pneumoconiosis. It is seen in coal miners. Okay, you can have aortitis, aortic regurgitation, chronic MR also. And hematologically, you can see anemia, neutropenia, okay, and splenomegaly in Felty syndrome. You can have thrombocytosis and eosinophilia, okay. Again, neurologically, you can have neuropathy, you can have myopathy and osteopenia, okay. So compression neuropathies, you can have them, especially carpal tunnel syndrome and tarsal tunnel syndrome. Cervical cord compression if the spine, the atlantoaxial joint is involved. Peripheral neuropathy or mononeuritis, again nerves are inflamed. And others, you can have systemic vasculitis, and amyloidosis is a rare complication. Then for diagnostic criteria, you have the EULAR criteria. I like to remember it as EULAR 1, 2, 3, 4, 5. So one extra is 6, okay. So greater than 6, if the score is there, it is definite rheumatoid arthritis, okay. So look at E, okay. So you have E for ESR. So ESR and CRP, if it is normal, then 0. If both are abnormal, then 1. Next, take the L. With L, look at the length or duration of the arthritis. The score should be 6, so the length also 6 weeks will take as criteria. Less than 6 weeks, 0. Greater than 6 weeks, 1. Okay, then look at the level of what two factors? Rheumatoid arthritis factors, RA factor and CCP. Okay, we already talked about this. Next, RA factor and CCP. So basically, if both are negative, 0. If both are low positive, then it is 2. And if both are high positive, then it is 3. Then based on the joint involvement, I like to remember it like this. See, 110, 3, 10, 10. Okay, 110 large joints, so one large joint is involved, and remaining 2 to 10 large joints are involved. Next, 3, 10, 10. 110, 3, 10, 10. So 1 to 3, 3 to 10, greater than 10. Okay, so based on small joints. So based on that, you have the score. So 0, 1, 2, 3, 5, 0, 2, 3, 0, 1, 0, 1. Okay, 0, 1 for the bottom two, and 0, 1, 2, 3, 5, 0, 2, 3. Okay, so based on that, you calculate the score. Again, investigations. So again, ESR, CRP, rheumatoid factor, anti-CCP, anti-nuclear antibodies can also be found. Synovial fluid analysis, okay, because synovial fluid, again, there's a swelling. And X-rays also you can take. They show osteopenia and non-proliferative erosions marginally. Okay, next, goals of treatment. First, there will be pain, so you can give paracetamol or NSAIDs. Okay, they don't change the outcome of the disease, but they reduce the pain. So again, you can give opioid analgesics like tramadol to control the pain. Okay, then you have DMARDs, so disease modifying anti-rheumatic drugs. So you have methotrexate. So methotrexate, you can give it at 7.5 milligrams per week. You should always give folic acid along with methotrexate. Then you can give HCQ up to 400 mg daily. So sulfasalazine, so A to Z, okay, so the alphabet. So A is 1, okay, so 1 gram twice daily. So Z looks like 2, so 2 times a day you give 1 gram. So steroids, again, same like methotrexate, 7.5. This also you'll give 7.5. So EULAR score 6, methotrexate and prednisolone 7.5 mg. So methotrexate per week, prednisolone per day. Okay, steroids are especially useful during flare-ups and during initial control. Then you have biological agents like anti-TNF agents. You have infliximab, rituximab, anti-B-cell, tocilizumab, so interleukin 6 inhibitor, all this. And immunosuppressive agents, you have azathioprine and cyclophosphamide. They are rarely used. Okay, so non-pharmacological measures, again, patient education and counseling, rest, exercise, physiotherapy, all this. Surgery, you can go for synovectomy. Next, Felty syndrome. If there is rheumatoid arthritis plus neutropenia and splenomegaly. So again, treatment, if the splenomegaly is severe and there is severe persistent neutropenia, severe thrombocytopenia because of hypersplenism, splenectomy. And again, because of neutropenia, you have to give gram CSF, so GCSF. Okay, treatment usually, otherwise it is the same as that for rheumatoid arthritis. Then again, both extra-articular and articular features of rheumatoid arthritis are more severe in Felty syndrome. So investigations, again, the same things you'll see. Ultrasound for splenomegaly. And other antibodies are also elevated in Felty syndrome, okay, like anti-dsDNA. Then moving on to rheumatoid factors. So it is usually of IgM class, although IgG and IgA is also seen. So basically you can see it in Sjogren, SLE, MCTD other than RA. So, and non-rheumatic disorders, you can see it in Hep B, Hep C, and combine this BC, so primary biliary cirrhosis, PBC. Next, anti-CCP also, it is more specific but less sensitive for the diagnosis of RA. It is used in early diagnosis of RA when the classical features are not present. So it can also be seen in SLEs, Sjogren's, and polymyositis and dermatomyositis. Both these factors can be present.